Good morning again, Section C. At this juncture, we are going to continue discussing adrenergic agents. Particularly, we will discuss the clinical uses of sympathomimetics. Again, we will focus on the clinical applications of sympathomimetics. O recall question lang, kapag sympathomimetics, anong sabi natin? Are these agonists or antagonists? Ano sila? Mga agonists. Okay, very good. So they are agonists. So lahat ng mga diniscuss nating adrenergic receptor effects, they do support those actions. So yung knowledge nyo sa mga receptor effects ang magiging basis nyo para maintindihan ang applications ng sympathomimetics. Number one are the clinical applications of endogenous catecholamines. Endogenous or natural catecholamines include epinephrine, norepinephrine, and dopamine based on your learning sa previous discussion natin. So let us discuss individually the clinical applications. Number one, for epinephrine, we have several applications relevant to epinephrine. Number one, this is deemed as the first-line cardiac stimulant. Actually, this application of epinephrine is directly attributable to its mechanism of action. If you could still remember, class, one of the actions of epinephrine is by activating beta-1 receptors. Okay? Isang action niya is by targeting or activating beta-1 receptors. And you knew that beta-1 activation could stimulate the heart. Kaya siya cardiac stimulant. Okay? Next, ang epinephrine, it can also be used as the first-line agent in the treatment of a condition called anaphylactic shock. Actually, maraming anaphylactic cases na pwedeng paggamitan ng epinephrine. So kindly add, aside from anaphylactic shock, another is during anaphylaxis, and also anaphylactoid reaction. Again, anaphylactoid reaction. So I repeat, additional applications related to anaphylactic cases, these are anaphylaxis and anaphylactoid reaction. So right now, i-differentiate natin yung mga tatlong conditions na yan, okay, para maintindihan natin. So first stop, we have anaphylactic shock. Again, anaphylactic shock. Una, para maintindihan natin ang condition na ito, let us explain first the term shock. Okay, let us explain first the term shock. When we talk about the term shock, this is a general term pertaining to hypotension. Okay, so pertaining to hypotension. So if a patient is experiencing shock, one of the effects that could be observed is hypotension or reduced blood pressure. Okay, and there are several reasons para mangyari ang shock or hypotension. Isang possible cause, isang possible trigger para mangyari ang hypotension, that is due to an allergic reaction, okay, due to an allergy. And ang tawag natin sa specific type of shock caused by allergy is anaphylactic shock, okay? That is anaphylactic shock. So during hypotension caused by allergy, first line is epinephrine, okay? First line is epinephrine. Now, ano ang relevance? I repeat, ano ang relevance ng epinephrine for hypotension caused by allergy? Remember, one of the actions of epinephrine is by activating alpha-1 receptors. Again, as you remember, one of the target receptors of epinephrine is alpha-1. Guys, recall question again. Kapag alpha-1, ano yung palatandaan yung epekto? Is it relax or contract? Very good. Okay, very good. So it's contract. Such as in the blood vessels. So pag activate ang alpha-1 caused by epinephrine, there is constriction of the blood vessels. And what do you expect when blood vessels constrict? Will it lead to increased blood pressure or decreased blood pressure?
Increase.
Okay, nice. So that would cause an increase in BP. With this being said, do you think this effect could counteract the problem in shock? Yes or no?
Yes.
Yes, okay, very good. So yan ang application ng epinephrine for anaphylactic shock, okay? Next, okay, again, next. What about for anaphylaxis and anaphylactoid reaction? So I put a bracket because meron silang similarity. Ang similarity ng anaphylaxis at anaphylactoid reaction, yung simptomas, yung simptomas na na-experience ng pasyente, yung manifestation sa katawan ng tao. Number one, with anaphylaxis and anaphylactoid reaction, parehas silang merong hypotensive effect. May hypotension effect sila. Kaya applicable ang epinephrine doon as we discussed a while ago. And also, during anaphylaxis and anaphylactoid reaction, ang isa pang effect is difficulty of breathing or shortness of breath. I repeat, we have difficulty of breathing. So these are the manifestations caused by both anaphylaxis and anaphylactoid reaction. Now, doon tayo mag-focus sa difficulty of breathing. Ang difficulty of breathing, of course, we have to treat this because this could lead to fatality. Yes, epinephrine can be used in this situation because, recall, amongst the natural catecholamines, amongst these three agents, only epinephrine has the ability to bind to what receptor? Anong receptor yon? Yung related sa ating paghinga. Is it alpha o beta?
Beta po.
Beta. Anong number? Anong number? 1, 2, 3?
2 po.
Yes, very good. So epinephrine is the only catecholamine, natural catecholamine, which activates beta-2 receptors. Okay, so yan ang application. Hopefully, by having this lecture, mas na-connect natin ang receptor sa use ng mga medications. Okay? So yan ang clinical manifestations ng anaphylaxis at anaphylactoid reaction. Now, ano ngayon ang difference? Yung color green, we will talk about the difference of anaphylaxis and toid reaction. Tandaan kapag anaphylaxis, this is IgE mediated. Okay, this is IgE mediated. So this requires formation of antibodies, particularly immunoglobulin E. Unlike anaphylactoid reaction, hindi siya IgE mediated. Okay, non-IgE mediated. And often, ang anaphylactoid reaction is caused by drugs, direct effects caused by drugs. So yan basically ang difference ng anaphylaxis and anaphylactoid reaction. Guys, pwede na po sa local vasoconstrictor application.
Yes po.
Okay.
Sir.
So very good guys. So far, I guess naiintindihan. Right now, let's focus on the application of epinephrine as a local vasoconstrictor. In terms of its relevance as a local vasoconstrictor, you will actually understand this because you knew earlier na alpha-1 agonist siya. Kaya it can constrict blood vessels. Pero sa clinical setting, ano ang kwenta ng epinephrine sa pagiging local vasoconstrictor? That is, ang epinephrine is being combined, this is being combined with lidocaine. This is being combined with another medication called lidocaine. Is everyone familiar to lidocaine? Are you familiar to lidocaine or no? Familiar ba sa lidocaine or
Narinig na
hindi?
po, sir.
Narinig na. Okay, very good. So, bigyan ko kayo ng overview about lidocaine. Number one, pag ang gamot, naalala ko bigla. Oo, narinig yun na yun, na-discuss ko yan sa OrgMeds dati. Pero anyway, tandaan guys, kapag ang gamot ay nag-end sa cane, isa siyang local anesthetic. Okay, so isa siyang local anesthetic. So just like other canes, ang lidocaine ay isang locally administered anesthetic agent. Sabi dyan, ang epinephrine, it is being combined to lidocaine. Now, sa anong klaseng practice ina-apply ito? During dental extraction, pag ikaw ay bubunutan ng ngipin, okay? During dental extraction. So, ginagamit ang lidocaine and epinephrine combination kapag bubunutan ka ng ngipin because of two major benefits. Okay? Two major benefits. So, number one, first benefit of combining this is to minimize bleeding. Okay? Number one is to minimize bleeding. Siyempre, kapag may vasoconstriction effect, controlled ang blood loss. Siyempre, pag may dental procedure, chances are, merong blood loss. Kaya, to minimize that, we can combine epinephrine to lidocaine. Okay? Next is to enhance, second purpose is to enhance local anesthesia caused by lidocaine. To enhance local anesthesia induced by using lidocaine. So right now, let's focus on the second purpose. Kasi ito yung medyo medyo bago sa atin or medyo malabo sa atin in terms of the rationale. Okay? So sabi dyan, to enhance local anesthesia. So bago natin i-explain yung purpose na ito, magbibigay ako or magkukwento ako ng konting background about lidocaine use. Dati, or history to HX, okay? Dati, ang mga dentista, ang ginagamit nila sa mga pasyenteng bubunutan ng ngipin, lidocaine lang, walang epinephrine. Usually, ina-apply ang lidocaine or ina-administer siya sa gums natin. Halimbawa, bubunutin yung bagang ko, ituturok siya sa gums malapit sa bagang ko, and that is through subcutaneous administration. Okay? So, i-administer siya. So, anong purpose nun? Common sense, para pag binunutan ka ng ngipin, hindi makirot. Kaya lang, napansin ng mga dentista na despite of administering lidocaine, nakikirutan, nasasaktan pa rin yung pasyente while performing the procedure. Bakit ganon? Nag-administer ka ng local anesthetic, dapat may anesthesia, pero bakit makirot pa rin? And based on evidences, na-discover na kahit pala magbigay ka ng lidocaine mag-isa sa gums ng pasyente, since injectable siya, chances are the drug lidocaine could enter the bloodstream. Okay, it could enter the bloodstream. What do you expect if a drug like lidocaine enters the blood? Do you think masisirculate ang lidocaine sa iba't ibang parts ng katawan? Yes or no?
Yes po.
Yes. Okay. So anong implication nun? Nadidistribute ang lidocaine sa ibang parts ng katawan na hindi naman dapat mangyari kasi hindi naman kailangan ng ibang parts ng katawan. The gums need it. Yun lang. Yun lang yung part na may kailangan ng lidocaine. Kaya nawawala ng saysay ang lidocaine. And because of that gap, naisip na i-combine ang epinephrine with lidocaine because epinephrine is a vasoconstrictor. And by doing so, pag nagkaroon ng constriction sa area kung saan in-administer ang lidocaine, nakukulong ang lidocaine, nakukulong siya, hindi siya makapasok na maayos sa blood, hindi siya ma-distribute. So kapag hindi siya na-distribute, highly concentrated siya sa area kung saan siya kailangan. That's why may enhanced local anesthesia. Kaya pag pupunta kayo sa mga dentista, ang ina-administer nila usually, combination na nila. May preparation actually na magkasama na yung dalawa para isahang turok na lang sa patient. Naintindihan po ba ang rasyonale?
Yes po.
Okay. So yan ang dalawang reasons, to minimize bleeding and to enhance local anesthesia. Actually, it's good news na hindi kayo familiar sa lidocaine ngayon. So ibig sabihin, or yung ganitong combination, kasi ibig sabihin, hindi pa kayo nabubunutan ng ngipin. O blessing yun pag di kayo nabubunutan ng ngipin. Okay? Next, okay na tayo guys sa local vasoconstrictor. And finally, wala sa notes pero pakidagdag, meron pa tayong isang application ng epinephrine. Okay? So meron pa tayong isang application ng epinephrine. Aside from local vasoconstrictor application, epinephrine is also used for glaucoma. So epinephrine is also used in the management of glaucoma. So when we talk of glaucoma, meron tayong specific preparation of epinephrine being used for glaucoma. Again, meron tayong specific preparation, and that preparation is a prodrug of epinephrine. And the prodrug of epinephrine for glaucoma is dipivefrin. Okay, this is called as dipivefrin. It's victory. Okay, so dipivefrin. So yan ang application ng epinephrine or prodrug na dipivefrin that is for glaucoma. Now, hopefully nakakasunod pa. Nasusundan pa ba ako? Okay.
Yes po.
Okay.
All right. Since ilang beses natin ma-encounter ang glaucoma at may encounter nyo rin siya sa mga tasks sa Module 1 sa Canvas, let me discuss some insights about glaucoma. Okay? I-discuss natin briefly ang sakit na glaucoma. Bago ko mag-start sa glaucoma, pwede ko nang burahin ang side notes.
Yes po.
Sige, burahin na natin ha. Focus tayo ngayon guys sa glaucoma. What part of the body is being affected during glaucoma? Anong part ng katawan?
Mata.
Yes,
Eyes.
very good. It's the eyes. Okay? Ang glaucoma ay isang example ng neurodegenerative neurodegenerative disease that affects the eyes. Okay, again, glaucoma is a neurodegenerative disorder that affects the eyes. And worse about glaucoma, it could affect both the eyes. Okay? Ang target ng glaucoma, kung bakit naapektuhan ang ating mata, that is because ang specific nerve that carries impulses papuntang utak ang nade-destroy. And that is, nagkakaroon ng destruction ng optic nerve. Okay? So, optic nerve destruction. Okay? So, this is caused by optic nerve destruction, which is the sensory neuron that carries impulses from the eyes going to the brain. So, yung tulay na nagdadala ng impulse ang nasisira. Kaya chances are, this could lead to blindness. Okay? So, pwede siya mag-cause ng blindness. So, para maintindihan natin ang relevance ng gamot in the management of glaucoma, i-explain natin kung bakit nasisira ang optic nerve. Okay? Ba't nasisira? Kung babalikan natin ang anatomy ng mata, okay, halimbawa ito yung mata natin, and this is the brain, papuntang utak, and this is the optic nerve. Okay? Optic nerve yung nagtutulay papuntang utak. Pag chinek natin ang anatomy ng mata, meron tayong dalawang divisions ng mata. The harap or the anterior portion and the posterior portion. Okay, anterior and also posterior portion. Now, ang problema sa glaucoma is nag-a-accumulate ang aqueous humor. Okay, nag-a-accumulate ang aqueous humor sa ating mata. I repeat, ang problem sa glaucoma leading to optic nerve destruction is nag-accumulate ang isang klase ng tubig sa mata. Ang tawag doon ay aqueous humor. Okay? So bago natin i-connect ang aqueous humor sa glaucoma, let me give you some insights about aqueous humor. Actually, ang aqueous humor, siya ay nutritional source ng ating mata. Okay? Nutritional source. So ito yung klase ng fluid sa ating mata na may daladalang iba't ibang nutrients para mabigyan ng well-nourishment ang ibang parts ng mata. Lalong-lalo na yung mga avascular parts, okay? Yung mga avascular structures ng ating mata. So aqueous humor provides nutrition sa mga avascular structures ng mata. And when we say avascular structures, ito yung mga parte ng mata na walang ugat. Siyempre, pag walang ugat, anong maiisip natin pag walang ugat? They don't receive enough nutrition, di ba? Halimbawa, cornea ng mata. Ang cornea, avascular yan. So wala siyang pagkukunan ng oxygen, ng iba't ibang nutrition or nutrients. Kaya ang nagpo-provide nun, aqueous humor. Kaya based on my lecture, do you think aqueous humor is important? Ha? Yes, okay. Important siya. Kaya lang, take note, dapat may regulation ng aqueous humor sa ating mata. Okay? Dapat may tamang regulasyon ng ating aqueous humor. And when we say regulation of aqueous humor, please take note that the rate of inflow, again, the rate of inflow of aqueous humor should be equal, it should be equal to the rate of outflow. Again, in regulating aqueous humor in the eyes, dapat the rate of inflow is equal to the rate of outflow. Or should we say, the amount of inflow is equal, must be equal to the amount of outflow. So medyo complicated ito ha. Binibigay ko muna yung mga important points para ma-connect sa drugs later. So at this point, i-focus natin ang regulation ng aqueous humor. That is, inflow must be equal to the outflow. What do we mean by that? Pag sinabi nating term ng inflow, ibig sabihin yan ay synthesis. A synthesis ng aqueous humor sa mata. At pag sinabi nating outflow, this has something to do with the excretion of aqueous humor in the eyes. So inflow is synthesis and excretion is outflow. So that's it. So ang point ng regulation, nakakasunod ba?
Yes po.
Okay. So ang point ng equality, ang point ng equality is dapat sa mata natin yung dami ng ginagawa na aqueous humor ay kasing dami ng ilalabas. Dapat equal siya. So yung nagagawa sa mata pagkabigay ng nutrients sa mga avascular structures, dapat ilalabas din ng mata natin. Okay? Yun ang importansya ng regulation. Para ang mata hindi maipon ng aqueous humor. Okay? So yun yung importance. Ngayon, ang problema sa glaucoma, sabi natin, masyadong dumadami ang aqueous humor. Ibig sabihin, kung masyadong marami ang aqueous humor sa ating mata, ang inflow at ang outflow ay imbalance. Okay? Hindi siya balanse. Naiipon sa ating mata. Okay? Naiipon sa ating mata. Kaya ang epekto, pag tumataas ang aqueous humor, question, pag naiipon ba ang isang fluid sa isang area, malakas ba ang puwersa sa area na yon? Lumalaki ba yung pressure? Yes.
Opo.
Kaya in glaucoma, masyadong tumataas ang isang pressure observed in the eyes called intraocular pressure. Okay? So IOP means intraocular pressure. Okay? So again, when we say IOP, it means intraocular pressure. So tumataas ang pressure sa mata kasi naiipon yung tubig doon called aqueous humor. So kung i-connect natin siya sa illustration ko kanina. So for example, yung color green na ilalagay natin. Halimbawa, ito yung aqueous humor sa mata natin na ginawa ng eyes itself. Okay? So yung aqueous humor na ginawa ng ating mata, kung maraming ginawa at konti ang inilabas, pwede bang maipon ang aqueous humor sa mata?
Yes po.
Yes. At pag naipon siya,
Yes po.
yes, very good. Tumataas ang intraocular pressure at pag tumaas ang intraocular pressure, ang tendency mag-recreate ito ng puwersa papunta sa posterior part. Kaya naiipit ang optic nerve. Naiipit siya. At pag naipit ang optic nerve, pwede siyang masira, mabubulag yung tao or it could lead to blindness. So yan ang glaucoma bilang sakit. Naintindihan?
Yes po.
Okay. O, recall tayo sa glaucoma ha. I-recap natin yung mga essential. Number 1, ang glaucoma, naiipon ang aqueous humor, kaya tumataas ang intraocular pressure. Kaya tumataas ang aqueous humor kasi hindi balanse ang ginagawa sa tinatapon. At pag naipon ng aqueous humor, tinutulak ng tubig yung mata natin papunta sa utak, papunta sa optic nerve. Naiipit ang optic nerve, nasisira siya. Kaya that could lead to blindness. Okay? So yan ang glaucoma. Can I erase this?
Yes po.
Okay. So ngayon, ano ang kahalagahan ng drugs for glaucoma like epinephrine? Di ba ang epinephrine ginagamit for glaucoma? Tandaan, ang goal ng mga anti-glaucoma drugs like epinephrine is to restore the balance. Okay, restore the balance. Ano yung sinasabi kong restoration of balance? Dapat ang dami ng inflow ay ma-equilibrate, kailangan maging equal sa rate of outflow. So how are we going to achieve that? Okay, again, how are we going to achieve that? So meron tayong dalawang objectives. Number 1 is to target inflow. Okay, number 1 is to target inflow. And number 2 is to target outflow. So makikita natin guys na may blanks na nakalagay. Okay, may blanks. So kayo, based on your understanding, please help me out in answering this. It's either enhance or reduce. So pag gagamit ka ng gamot in restoring inflow and outflow, ano ang dapat i-answer sa to blank inflow? Is it to reduce or to enhance inflow?
Reduce.
Yes, very good. So it must be reduced. So to reduce inflow. By reducing inflow, do we tend to prevent accumulation of aqueous humor in the eyes?
Yes.
Yes, very good. Okay. Sa outflow, anong answer?
Enhance.
Yes, very good. Enhance or increase. That's right. To enhance outflow. By enhancing outflow, pinaparami natin ang clearance o paglabas ng aqueous humor. Do you think nalilesen ang pressure sa mata in that case? Yes. Kaya ultimately, ang mga gamot, ang outcome with the use of those drugs is to lower intraocular pressure. Okay? That is to lower intraocular pressure. So ayan, I think na-discuss ko na yung important aspects ng glaucoma. Kaya pwede na nating i-connect ang epinephrine. Ang epinephrine, i-highlight ko, ito ang kanyang action to enhance outflow. Okay? So yung action ng epinephrine is by enhancing outflow. Okay, so we are done with epinephrine. Finally, tapos na tayo sa epinephrine. Next, pwede na po ba tayo sa norepi?
Yes po.
Okay, norepinephrine is first-line agent naman for septic shock. Another shock condition, ang norepinephrine or ang septic shock is caused by infection naman. Okay, this is caused by infection such as bacterial infection. Again, norepinephrine is caused by bacterial infection. And then finally, for dopamine naman, dopamine can be used as an alternative agent, in the management of cardiogenic shock. Ang cardiogenic shock ay isa na namang halimbawa ng shock condition or hypotension. But in this regard, ang cardiogenic shock ay caused by heart failure. Okay, this is caused by heart failure. Again, dopamine is caused or is being used as an alternative agent for cardiogenic shock, and cardiogenic shock is caused by heart failure. And then dopamine can also be used in the management of congestive heart failure. Usually, makikita natin dyan, parehas may application ang dopamine for heart failure. Pag sinabi nating heart failure, ang heart does not contract well. Okay? So ang problem in heart failure, there is significantly low or reduced myocardial contractility by the heart. Kaya when we want to counteract heart failure, one of the goals is to enhance contraction. Okay? Palakasin ang tibok ng puso. Dopamine can be used for these cases because meron siyang beta-1 effect. Okay? Meron siyang beta-1 effect, thus enhancing force of contraction or inotropy. So these are the applications of natural catecholamines, epinephrine, norepinephrine, and dopamine. Next, let's proceed on the clinical applications of direct-acting sympathomimetics. These are selective agents. Okay? Number one, we have phenylephrine and methoxamine. Ang phenylephrine and methoxamine, these are alpha-1 agonists. Okay? So these are alpha-1 agonists. Question, pag alpha-1 agonist, sila ba ay constrictors or dilators?
Constrictors.
Yes, very good. So these are constrictors. Hence, they can be used as nasal and ophthalmic decongestants. Okay, decongestants. So bilang nasal decongestants, they can be used kapag clogged ang nose natin. At sa ophthalmic decongestants, usually, ang mga alpha-1 agonists, sila yung ginagamit for red eyes. Okay, for red eyes. Kaya pag nakita niyo yung eye mo, for example, eye mo red eyes, ang active ingredient doon ay isang alpha-1 agonist. Okay? Because of constrictor effect, nalilesen ang cutaneous vasodilation in the eyes. Kaya tendency, hindi namumula. Kaya ginagamit ang alpha-1 agonist kapag red or namumula ang mata natin. Okay? What else? Ginagamit din ang mga alpha-1 agonists as mydriatics. Okay? So again, ginagamit din sila as mydriatic agents. Recall question, pag mydriatic, enlarge or constrict ang pupils?
Enlarge.
Okay, so enlarge or dilatation of the pupils. And when we talk of mydriatics sa alpha-1 agonist, saan ito clinically useful? Ginagamit to during retinal exam. Okay, during retinal examination. Ginagamit ang mydriatics like phenylephrine and methoxamine, lalo na yung phenylephrine, as mydriatic agent during retinal exam. O anong ibig sabihin? Bakit kailangan gawin ang retinal exam? Ginagawa ang periodic retinal exam in patients with diabetes mellitus. Okay, so this is being performed in patients with diabetes mellitus. So what's the connection? For some of you, may kakilala kayong may diabetes. And you have to inform them na one of the complications of DM is blindness. Okay? Isang epekto ng DM, long-term effect ng DM ay pagkabulag. Kaya sa mga pasyente na na-diagnose na may DM, isang routine exam na dapat gawin sa kanila, i-check usually ang retina ng patient kung pwede na ba siya mabulag or meron ng threat ng pagkabulag. Okay? Now, para ma-assess ang retina ng pasyente, kailangan makita ng buo yung retina during ophthalmologic exam. For example, ito ulit yung mata, tandaan, meron tayong anterior at posterior, harap at likod na area. Ang problema is, ang retina natin ay nasa posterior part. So pag gumamit ka ng typical device para i-view ang retina, mahirap siyang tignan kasi may mga nakaharang sa anterior portion at isa na doon ay ang pupil. Nakaharang siya kaya hindi makita na maayos. So ang paraan para makita full view ang retina, kailangan mag-give way ang pupil. Kaya ang ginagawa, binubuka ang pupil, pinapalaki siya para makita ng maayos ang retina. So paano mo ibubuka ang pupil? Kailangan mo ng mydriatic agent. Ina-administer siya ophthalmic, okay? Ini-instill sa ating mata. Guys, na-gets nyo?
Opo.
Okay, so yun yung reason kung ba't gumagamit tayo ng mydriatic pag i-check up ang retina. Next stop tayo. Applications naman ng clonidine, methyldopa, guanfacine, and guanabens. These are presynaptic alpha-2 agonists and they are antihypertensives. Okay, they are antihypertensives because of their vasodilatory action. Next, for apraclonidine and brimonidine, these are also alpha-2 agonists. Alpha-2 agonists din sila, post-synaptically acting. And regarding these agents, they are anti-glaucoma. Now, ano naman ang kanilang mechanism of anti-glaucoma action? That is, they decrease inflow. Okay, they decrease inflow. Guys, pag dinerecho ko na ganitong decrease inflow, nagets nyo na? Nagets nyo na ba?
Yes po.
Okay, so they decrease inflow, thus lowering intraocular pressure. Okay? Next, isoproterenol. Isoproterenol is a beta agonist, non-selective beta agonist. Non-selective meaning to say it acts both at beta 1 and beta 2 receptors. First stop, by activating beta 2 receptors, isoproterenol could be a bronchodilator based on what you have learned so far. Okay? And also, ang isoproterenol, it activates beta 1 receptors. And beta 1 is heart, okay? Usually sa puso. That's why it can counteract AV block. Ang AV block is characterized by negative dromo effect. Okay? Negative dromo kapag sa AV conduction block. So ginagawa ng isoproterenol is it activates beta 1, thus promoting positive dromotropic effect. So baliktaran siya. Okay? So positive dromotropic effect. These are the applications of isoproterenol. But let me mention, in terms of its beta 2 effect or beta 2 action, it is already historical. Okay? It is already historical or hindi na siya applicable nowadays. Next, pwede na po kay dobutamine.
Yes po.
Yes,
Okay.
sir.
My teacher in college pronounces this as dobutamine. Kaya naa-amaze ako pag minimension niya to. Masarap sa feeling sa pharmacology rin kapag natututunan mo yung tamang pronunciation sa drugs. Actually, maraming pronunciation sa drugs na hindi natin nabibigkas ng tama sa Pilipinas. Pero kasi kapag pinronounce mo siya ng tama, parang alam mo yon may may bashing agad na naka-associate. Parang anggara pakinggan, nakakatawa pakinggan, payaman pakinggan, pero yun talaga ang tamang pronunciation. So halimbawa, dobutamine. Okay? So for dubutamine, this is the first-line agent for cardiogenic shock. Nabanggit natin earlier na pag cardiogenic shock, this is hypotension caused by what condition? Is it allergic, is it infection, or is it heart failure?
Heart failure.
Allergy.
Okay, so very good. So it's heart failure. Ang dubutamine ay isang beta-1 agonist. Okay, this is a beta-1 selective agonist. By saying that this is a beta-1 agonist, do you think dubutamine is a cardiac acting drug? Is this a cardiac drug?
Yes.
Yes. Is this a stimulant or a depressant in the heart?
Stimulant.
Okay, stimulant. Kaya nakaka-counteract ang mga heart-related cases like heart failure. Next, these are beta-2 agonists. Yung mga nakalistang examples dito, everyone, ay mga beta-2 agonists. First, we have metaproterenol, albuterol, terbutaline, and other related drugs. These are bronchodilators. And by being bronchodilators, this can be used for bronchial asthma, and also COPD. Okay, these agents can be used in the management of bronchial asthma and COPD because they can reduce the bronchial tone. You can check what the COPD mean in the Google, but it's chronic obstructive pulmonary disease. Okay, so that is COPD. And I discussed yesterday that these are bronchodilators comprising of SABAS and LABAS. Nare-recall ba kahapon nung diniscuss natin ang mga ito?
Yes po.
Okay, very good. So we have SABAS and LABAS. So just check which of them are SABAS and LABAS. Next, we have Ritodrine. Pakibura na ang isoxaprine dito kasi in this regard, ito ay off-label na. Okay, off-label, meaning hindi na siya clinically useful as a uterine relaxant. Kaya ang existing na lang are Ritodrine and also isoxaprine. Okay? Being uterine relaxants, na-discuss natin yesterday, they can be used in the treatment of preterm or premature labor. And in pharmacology, anong tawag natin sa ganitong drug group? Anong tawag natin? Letter T, starts with letter T?
Tocolytic.
Okay, very good. So these agents are tocolytics or pampakapit. Okay? So these are the clinical applications of beta-2 agonists. O para hindi kayo maiwan sa discussion natin, let's recall briefly the things that we have discussed so far. So regarding clinical uses, we started with direct acting. Okay? Sa direct acting, di ba, meron tayong non-selective. Non-selective are the catecholamines. So na-discuss natin ang clinical uses nila. And then for selective agents, na-discuss natin ang alpha-1 agonist, ang alpha-2 agonist, ang mga beta agonists like non-selective, beta-1 selective, beta-2 selective. So all of those clinical uses are for direct acting. Now, clinical uses naman tayo ng mga indirect acting mimetics. Regarding indirect acting, we have two subclasses, the releasers and reuptake inhibitors. Regarding releasers, we have examples amphetamine and methamphetamine. Both agents can be used for ADHD. Okay? Both agents can be used for ADHD. Only that, ang first line is, na-overlook ko, burahin ko ha, methamphetamine pala nakalagay dito. O, lagay natin ha, amphetamine and methylphenidate, both of these agents are being used for ADHD. Okay? Both of these agents are being used for ADHD, but the difference is, ang methylphenidate ay first line agent, and ang amphetamine ay alternative agent. Okay? So methylphenidate is first line, while amphetamine is alternative. Now, what about methamphetamine? Ang methamphetamine class ay ginagamit before for ADHD, kaya lang ngayon seldom na siyang ginagamit for this case. Kasi naaabuso ito eh. Siya actually yung shabu, 'di ba? Na-discuss natin siya yesterday. Siya actually yung shabu. So these are releasers. Next, we also have phenmetrazine and modafinil. Na-discuss ko na yung methylphenidate kanina, so it's already fine. For phenmetrazine, this is being used as an anorexant and therefore a popular drug of abuse. Popular drug of abuse siya because it targets the brain. Okay? It targets the brain. That's why it is habit forming. Okay? It is habit forming. So that's phenmetrazine. By the way, what does anorexia mean? Ano ibig sabihin ng anorexia? Anorexia is a drug that affects appetite. Okay? It can alter the appetite of a person. It's either suppressant or stimulant. What do you think? What do you think does anorexia mean? Di ba nababasa niyo siguro sa internet, oy may anorexia siya. O pag anorexic yung tao, sobrang taba o sobrang payat?
Payat.
Payat.
Yes, very good. So ang anorexia ay isang appetite suppressant. Okay, suppressant. So again, phenmetrazine is an anorexia or an appetite suppressant. Okay, very good. And then, ang modafinil naman, this is being used in the treatment of narcolepsy. Okay, ginagamit siya in the treatment of narcolepsy. Are you familiar with the term narcolepsy? Okay,
Yes.
very good. So ang narcolepsy ay isang clinical condition wherein merong sudden fall of asleep ang isang tao. Ito yung kakakausap mo lang as in milliseconds after. Pagtingin mo sa kanya, tulog na siya. May loss of consciousness. Not necessarily nag-pass out, hindi siya hinimatay, nakatulog talaga siya. Okay, nakatulog bigla. Marami may ganito pag may klase ako, lalo na sa hapon. Hindi na ako mag-mention, pero I know many. Pero biro lang. So for narcolepsy, ang ginagamit natin ay modafinil. At ang modafinil ay applicable because meron siyang arousal effects. Okay? Meron siyang arousal effects. Okay? So recap tayo. For releasers, we have amphetamine, methylphenidate, and also we have methamphetamine, phenmetrazine, methylphenidate, and modafinil. Now, para maka-relate kayo sa dinidiscuss natin sa releasers, actually, ang mga indirect acting sympathomimetics, sila yung mga ginagamit na mga party drugs. Okay? Sila yung mga ginagamit na party drugs. In fact, meron tayong idea sa isang common example ng party drug na under ng sympathomimetic. You know ecstasy? Have you
Yes
heard
po.
ecstasy?
Yes po.
Aware ba kayong party drug siya?
Yes po.
Okay. Ano ang ecstasy? Ang ecstasy ay derivative ng amphetamine. Okay? So related siya kay amphetamine. At ang ecstasy ay may chemical name na MDMA. Hindi ko itatanong ito sa mga assessments natin kung ano meaning na MDMA. Mahaba siya. Check nyo na lang sa net, methylene dioxymethamphetamine. Ang gusto ko lang malaman nyo, derivative siya ng amphetamine. Okay? So regarding ecstasy or methylene dioxymethamphetamine, ang ecstasy ay isang party drug. Pag sinabing party drug, that keeps you alive during party. Di ba ang party, usually gabi. Ayaw mo naman mag-party nang inaantok ka, di ba? Ayaw mo nun. Kasi, ang gusto mo, meron kang enough energy para makipag-socialize. Kaya ginagamit ng mga tao ang ecstasy kasi it enhances sociability. Kumakapal ang mukha ng tao, nawawala yung hiya. Sa party, dapat walang hiya ka, di ba? So yon. Kasi meron din siyang arousal effects, ecstasy. Kaya lang ang problem, sympathomimetic siya, nakakamatay siya. It can cause death. Why? Ang ecstasy, releaser. So imagine niyo, pinaparami niya ba ang norepinephrine that binds to the receptors? Yes. So pag pinarami niya ang norepinephrine, what do you expect? Maraming pupunta sa alpha-1 receptors. Maraming pupunta sa beta-1 receptors. Can alpha-1 cause hypertension? Yes, it can cause hypertension. And then beta-1, does it cause tachycardia? Does it target the heart? Yes. So ang problem kapag may too much exposure to ecstasy, pwede kang atakin sa puso. Okay? Pwede kang atakin sa puso. Kaya totoo yung nakikita nyo sa mga balita minsan na ecstasy can cause death. Okay? And habit forming siya. So that's it. Okay? Next, applications naman tayo everyone ng reuptake inhibitors. For reuptake inhibitors, we have cocaine. Anong sabi ko pa nag-e-end sa cane? Local anesthetic. Okay? Ngayon, ang cocaine, ang distinct characteristic ng cocaine, this is the only local anesthetic that causes vasoconstriction. Okay, this is the only local anesthetic drug which causes vasoconstriction because other local anesthetics can cause vasodilation. Okay, so distinct yun kay cocaine. And then atomoxetine is also used for ADHD, and sibutramine is being used for obesity. Why? Because just like phenmetrazine earlier, sibutramine is an anorexin agent. So these are reuptake inhibitors. Section C, can we proceed on the next slide?
Yes po.
Okay.
Yes po.
Moving on, we have mixed-acting sympathomimetics. Recap regarding mixed-acting sympathomimetics, these agents have both direct and indirect actions. We have ephedrine. Ephedrine has also an anorexin activity. That's why it can be used for narcolepsy. Mephentermine and metaraminol for hypotension because of their constriction effect by activating alpha-1 receptors as well. So by doing so, merong increased blood pressure activity. And then finally, phenylpropanolamine, which is also used as a decongestant in orally administered OTC agents. So these are mixed acting sympathomimetics. Everyone taken all together, these are the clinical uses. Brief review for you to follow the lecture. For the clinical uses, we enumerated and explained the clinical applications of direct acting, which includes non-selective and also selective agents. And then we discussed the applications of indirect acting and mixed acting. Lahat yan yung gamit sa medicine. Okay? Siyempre, associated or coupled with the use of those agents are the adverse effects. Kaya punta tayo sa mga toxicities brought about by using sympathomimetics. Take note, ang mga common toxicities exhibited by these drugs are related to the MOA. Okay? They are related to the MOA. When we say related to the MOA, if you are knowledgeable with the receptor effects of these drugs, you can predict the adverse effects. You can foresee what's gonna happen. Number one, for catecholamines, remember that catecholamines are non-selective. They can activate both alpha and beta receptors. That's why if there is prolonged use of catecholamines, chances are there's also extension of their alpha and beta effects. Okay? So merong extension ng alpha and beta effects. Halimbawa, when there is extension of alpha effect, syempre, merong persistent vasoconstriction. And often, ang affected sa katawan natin, kapag may persistent vasoconstriction, ang mga daliri. Okay? Yung mga daliri ang naapektuhan. Ang mga ugat sa daliri ang naapektuhan, resulting in digital necrosis. Okay? Resulting in digital necrosis. What do we mean by digital necrosis? Guys, nakikita niyo yung daliri ko? Ha?
Yes po.
po.
Sir.
So, nakikinig pa kayo?
Yes
Okay.
Sir.
Nice. So for digital necrosis, when we say necrosis of the digits, the cells of your fingers, they die. Namamatay sila. Why? Because salat sila sa nutrients na nare-receive. Kulang na nutrients ang nare-receive nila. Because of the constriction of the vessels in the fingers, limited ang blood supply na nakakarating sa daliri, namamatay ang mga tissues doon. Kaya yung mga patients na may digital necrosis, makikita nyo sa mga daliri nila, parang patay yung kuko, nagko-color violet kasi nga cells in the digits, they die, namamatay. That's why one of the monitoring that you can do pag nagbibigay ng catecholamine sa pasyente, check the digits kung namamayulet na siya. Ibig sabihin, pwede nang adverse ang activity ng mga natural catecholamines. Okay? Next, for beta effect naman, beta extension, sa tingin nyo, anong part ng katawan ang mako-compromise kapag may extension of beta effects? Or beta 1, particularly beta 1. Ano ang
Heart.
Yes, very good, heart. Kaya pwede magkaroon ng tachyarrhythmias. Okay, that's why tachyarrhythmias could occur. So may abnormal rhythmic activity ang puso ng patient, and that could have cardiovascular complications in the future. Okay? So yan. Ang point is related sa MOA, so it's predictable. Okay? Next, in some situations, there could also be CNS disturbances, and this is applicable to non-catecholamines. Okay? This is applicable to non-catecholamines. Question, bakit applicable ang CNS disturbances sa non-catecholamines? What did you learn yesterday? What did I tell you? Ang mga non-catecholamines, can they enter the brain? Yes or no?
Yes.
Yes. Ang catecholamines, can they enter the brain?
No.
No, very
No
good.
po.
Kaya wala silang CNS disturbances. So it really makes sense. So for CNS disturbances caused by non-catecholamines, we have nervousness, anorexia, insomnia, anxiety, aggressiveness at times, paranoia, and convulsions. Moving on, adverse effects of selective agonists. Selective, ibig sabihin, may specific receptor type lang silang tinatarget. And take note, these adverse effects are directly associated with their actions pa rin. It's predictable. Number one, alpha-1 agonists can cause hypertension. It is obvious because of their constriction effect. Okay, so because of their constriction effect. Next, for beta-1 agonists naman, they can cause cardiac toxicity because puso ang target, like sinus tachycardia and arrhythmias. Beta-2 agonists can cause tremor of the muscle. So pwede manginig yung tao because of persistent contraction. And also, these agents could alter blood potassium, right? Kahapon, anong sabi natin? Kapag na-activate ang beta-2, what's the effect? Is it hyper or hypokalemia?
Hypo.
Very good. Very good. So it's hypokalemia. Kaya pag gumamit ng beta agonist ang tao, chances are bumababa ang potassium niya. Kaya bumababa ang potassium. Hindi ko alam kung merong may asthma sa inyo at gumagamit ng isang beta-2 agonist like salbutamol. Pero common side effect ng salbutamol, pag ninebulize, yung tao nanginginig siya. Kaya nagtatremor siya. Effect yun ng beta-2 agonist. Okay? And then finally, cocaine. Cocaine is a common drug of abuse. And it can cause cardiac arrhythmias, myocardial infarction, and lastly, we have convulsions. Okay? So overall, guys, that is the end of the adverse effects of adrenergic agonists. And from yesterday up until now, we were able to finish sympathomimetic drugs. Brief review tayo sa sympathomimetics, yung outline na naggawa natin. Sa sympathomimetics, kung papansin nyo, nag-discuss tayo ng number 1, classes ng sympathomimetics. Dito natin diniscuss na meron palang based on chemistry at meron based on MOA. Can you still follow me? Are you still with me?
Yes, sir.
Okay. And then, we enumerated the examples of these classes. Kaya na-discuss natin yung mga drug names. Okay? And then, pangatlo, clinical uses. Clinical uses. And then finally, ano yung huling portion na diniscuss natin? Yung mga adverse effects. Okay? Yung mga adverse effects. Ba't ko to sinabi? Para pag nag-aral kayo ng PowerPoint, naka-structure yung aaralin nyo. So I highly recommend na kapag nag-aral kayo ng mga gamot sa chapter na to, gawa kayo ng outline sa isang note paper, tapos lagay nyo classes, tapos example, etc. etc. And then once you are done with it, checkan nyo. And then i-recall nyo sa isip nyo, classes, ito yung diniscuss, ito yung diniscuss. At least, may flow yung discussion nyo. Pansin ko kasi sa mga estudyante, regarding sympatholytics, take note, there is total shifting of thoughts here. Okay, may total shifting of thoughts. Kasi when we say sympatholytics, when we say lytic, this tells us na we lyse or we break sympathetic effect. That's why these are being termed as adrenergic antagonists. Kaya yung mga natutunan nyo na mga receptor effects ng adrenergic, ma-oppose nila. For example, kung kanina sa agonist, puro constriction ang effect na nangyayari, dito magkakaroon ng relaxation. Okay? Nagkakaroon ng relaxation ng blood vessels, for example. Kung kanina may cardiac stimulation, dito, what do you think? Since antagonist, that can cause depression of the heart and other applicable effects. So, ia-antonyms lang natin. Okay? So, para maintindihan natin ang sympatholytics, ganun pa rin ang gagawin natin. I-discuss natin ang classifications ng sympatholytics and also examples, clinical uses, and toxicities. First stop are the classifications of sympatholytic agents, and this is based on their selectivity of action. Okay? Or mechanism rather, mechanism. Purahin natin. So based on, nakasulat na pala, based on mechanism of action. So based on mechanism of action, we have two classes of adrenergic antagonists. Number one are the direct acting. Ay na-discuss na natin to kahapon or kanina, I guess. And then peripherally acting sympatholytics. Regarding direct acting sympatholytics, we have two classes based on selectivity. Okay, based on selectivity of action. These are alpha blockers. These are alpha blockers and beta blockers. Yan ang i-discuss natin later. And then for the second group, we have the peripherally acting sympatholytics. And these are generally called as adrenergic neuronal blockers. Kaya pag gumawa kayo ng notes, i-outline nyo na siya. Based on MOA, number 1, direct acting. And then we have alpha, beta. And then number 2, peripherally acting, we have the adrenergic neuronal blockers. Mamaya may encounter nyo ang mga specific examples. Okay, so yan yung style in studying. So moving on, let's have direct acting. Okay, direct acting sympatholytics. I repeat, we have two classes. These are alpha and beta blockers. Unahin natin ang alpha blockers. Guys, habang sinasabi ko ang pangalan nila, sana meron kayong fino-foresee na epekto nila. Since they block alpha receptors, sana ma-connect nyo siya sa receptor na dinidiscuss natin kanina at kahapon. Okay? Let's enumerate first the examples. We have different subclasses of alpha blockers depending on which receptors they target. Number 1 are the non-selective. Okay? Number 1 are the non-selective alpha blockers. When we talk of non-selective alpha blockers, apparently, they block both alpha-1 and alpha-2 receptors. So meron tayong dalawang examples ng non-selective alpha blockers. Number 1 is phenoxybenzamine. Number 1 is phenoxybenzamine. Second is phentolamine. Okay, again, number 1 is phenoxybenzamine. Number 2 is phentolamine. What's the difference between these two? Again, what's the difference? Ang difference nila or differences nila, number 1 is for phenoxybenzamine, irreversible drug siya, while phentolamine, reversible siya. That's the first difference. Okay? Secondly, ang phenoxybenzamine, it acts non-competitively. Okay? It acts non-competitively. Whereas phentolamine, it acts competitively. So competitive blocker for phentolamine. Again, for phenoxybenzamine, it is irreversible and also non-competitive. While for phentolamine, again for phentolamine, it is reversible and competitive. Okay? Yan ang differences sila. But, I repeat, but both are non-selective. Okay? Both are non-selective. That's the first subclass. Next, after natin sa non-selective, we also have alpha-1 selective blockers. Okay. Next, we have the alpha-1 selective blockers. And alpha-1 selective blockers are the ones in the left portion. Okay. Examples ang palatandaan, these are the agents that end in zosine. Okay. These are the agents that end in zosine. Like, ang tamang pronunciation dito, it's not prazosine, it's prazosine. Okay, so prazosine, doxazosine, terazosine, alfuzosin, and hindi sounds like zosine pero medyo malapit, but example din si tamsulosin. Okay, examples are prazosine, doxazosine, terazosine, alfuzosin, and tamsulosin. And for the last subclassification, alpha-2 blocker, okay, alpha 2 selective blocker. There are two examples. Number one is yohimbine, and second, not written but you can add, rawolsin. Examples of alpha-2 selective blockers are yohimbine and also rawolsin. So these are the examples of alpha blockers. Take note of the drug names. Next, we have beta blockers. At a first glance, again, at a first glance, madali nating malaman kapag ang isang gamot ay isang beta blocker kasi nag-end sila sa olol. Kaya lang, napakadaming beta blockers, napakadami nag-end sa olol, kaya pag nagsama-sama na sila, it's quite confusing already, especially when we recognize the specific examples. So meron tayong mga classifications ng beta blockers. So meron tayong dalawang basis of classification. Again, meron tayong dalawang basis of classification sa beta blockers. Number one is based on their selectivity of action. Okay, number one is based on their selectivity of action. And number two, that is based on their miscellaneous action. Okay, again, selectivity of action and based on miscellaneous actions. Hello? So meron akong inarrow na color blue sa beta blockers. Bago natin i-discuss yung selectivity and miscellaneous actions, dun muna tayo sa general MOA, general MOA ng beta blockers. As I've said, ang dami nating examples ng beta blockers. Lahat ng olol. Pero kahit maraming beta blockers kayo ma-encounter, meron silang lukso ng dugo. Meron silang common denominator. Ang common denominator nila is meron silang general mechanism of action. That is, lahat sila ay beta-1 antagonists. Okay? So lahat sila ay beta-1 antagonists. When we say that they are beta-1 antagonists, what would you realize? They target the heart, yes. So ano ang effect nila sa puso? Is it cardiac stimulation or cardiac depression?
Depression.
Yes, very good. So that causes cardiac depression. That's why ang effect generally ng mga beta blockers ay negative, meaning pine-prevent, kina-counteract ang inotropy, chronotropy, and also dromotropy. Okay, so they promote negative inotropy, chronotropy, and finally dromotropy. Can you still remember these medical terms involving the heart?
Yes po.
Yes. Alin sa tatlo ang strength?
Inotropy.
Yes, inotropy. Alin dyan ang AV nodal conduction velocity?
Dromo.
Yes, that's right.
Dromo.
Ano ang chrono?
Heart rate.
Heart rate.
Yes, that's right. Okay, yung bilis ng tibok. Very good. So lahat ng beta blockers may effect na yan. Now, anong connection ng general MOA sa binanggit kong selectivity at miscellaneous actions? As I've said, ang daming beta blockers. And these beta blockers could have other effects than beta-1 blockade. Meron pa silang ibang kayang gawin on top of their beta-1 blocking effect. Okay? So yun yung i-discuss natin. So una, selectivity. So regarding selectivity, meron tayong dalawang grupo. Okay? Meron tayong dalawang grupo. So ito yon based on selectivity. Okay? Based on selectivity. Number one, we have beta-1 selective blockers. Ang beta-1 selective blockers, they are also known as cardioselective. Okay? They are also known as cardioselective blockers. Examples are bisoprolol, betaxolol, esmolol, acebutolol, metoprolol, carvedilol. Or sorry, not carvedilol, carteolol. Okay? So, yan ang mga examples ng beta-1 selective blockers. Now, sila lang ang grupo ng beta blockers na nakafocus sa beta-1 antagonism yung action. Next, what about non-selective? When we say non-selective, beta blockers, both beta-1 and beta-2 are being blocked. Okay? So both beta-1 and beta-2 receptors are being antagonized. Examples are nadolol, sotalol, timolol, and propranolol. Again, examples are nadolol, sotalol, timolol, and propranolol. Ang ating palatandaan ay NSTP. So yung kanina, beam naman. Okay, beam. So NSTP, nadolol, sotalol, timolol, and propranolol. Nakapag-NSTP kayo last SEM or last year?
Yes po.
Yes.
Okay. Ang NSTP natin sa CEU ay CWATS. Siguro nag-ano kayo, nag-immersion kayo, di ba? Nagturo kayo sa mga bata, naglinis kayo. Kami ganun din ginawa namin. So palatandaan dito is, para makapasa ka ng NSTP, dapat hindi ka maarte. Dapat non-selective ka. Okay? So yun yung palatandaan natin dyan. Okay? Now, regarding non-selective beta blockers, again, regarding non-selective beta blockers, meron silang major contraindication. Ang NSTPs ay bawal sa mga taong may bronchial asthma. I repeat, use of NSTP is contraindicated to patients with bronchial asthma. Para malinaw, siguro medyo bago sa inyo ang term na contraindication. When we say contraindication, ganito siya kasimple. Ito yung isang sitwasyon na meron ng tao na nagiging dahilan kung bakit bawal ang gamot sa kanya. Naintindihan ang ibig sabihin ng contraindication?
Yes,
Yes.
po.
Okay. So halimbawa, sa taong may bronchial asthma, huwag mo siyang bigyan ng kahit ano sa NSTP. Bawal. Okay? Major contraindication. Question. Why? Why? What do you think? Kailangan ko ng bolang kristal.
Tox beta 2.
Yes, very good. Very good, Miss Reyes. So nabablock ang beta 2. So for everyone's information, ang mga NSTP, binablock din nila ang beta 2. Question for everyone. May connection ba ito sa bronchial asthma?
Yes po.
Yes.
sir.
Pag binlock ang beta 2, is it easier or harder to breathe? Harder because of bronchoconstriction. Do you think pag merong bronchoconstriction, mapapalala ba ang bronchial asthma patient?
Yes.
Yes, kaya contraindicated. Instead, ang pwede nating ibigay, cardioselective, okay? Pag may bronchial asthma. Nice. Next, bago tayo mag-proceed sa aspetong ito, okay? Bago tayo mag-proceed sa aspetong ito, dito muna tayo sa introduction ng based on miscellaneous actions. Guys, based on miscellaneous actions, ibig sabihin yan, on top of beta-1 blocking effect, may iba pa silang activity. Meron tayo mga beta blockers na merong ISA. Ano muna ha, introduction. So ISA, meron namang membrane stabilizing action, membrane stabilizing action, and alpha-1 blockade. Alpha-1 blockade. So there are beta blockers that have ISA, membrane stabilizing action, and alpha-1 blockade. So ano-ano yung mga beta blockers na yan? Number one, for beta blockers with ISA, ang ibig sabihin ng ISA ay intrinsic sympathomimetic activity. Okay, again, it means intrinsic sympathomimetic activity, meaning to say, these beta blockers also possess mimetic effects. Okay, they can also activate. And the specific receptors that they can activate is beta 2. Okay, they can activate beta 2. So the point here is, these beta blockers block beta 1. These beta blockers block beta 1, but they activate beta 2. Kaya meron silang blocking effect at mimetic effect. Okay, so yun yung beta blockers with ISA. Examples are acebutolol and pindolol. Next, we have beta blockers with alpha-1 blocking effect. Ito yung may alpha-1 blocking effect. For beta blockers with alpha-1 blocking effect, these are the drugs na may additional vasodilation effect. Okay, so these are the agents that have vasodilatory effect. That is, we have labetalol and carvedilol. Okay, next, paki-edit yung pangatlo, which is butoxamine. This is under based on selectivity. Okay, this is under based on selectivity. So pakilipat na lang siya sa previous slide. Okay? Ang idagdag natin dito, number 3, nagets ba yung instruction?
Yes po.
Okay. So number 3, everyone, meron pa tayong natitira that is membrane stabilizing. So for the third classification, under based on miscellaneous actions, we have beta blockers with membrane stabilizing action. For beta blockers with membrane stabilizing action, these agents possess local anesthetic effect naman, okay, with local anesthesia. Again, these beta blockers possess additional local anesthetic effect. The following are the examples. Number one is propranolol. Okay, number one is propranolol. Second is acebutolol. Again, examples are propranolol. Second is acebutolol. Next, we have labetalol and metoprolol. I repeat examples of beta blockers with membrane stabilizing action. These are propranolol, acebutolol, labetalol, and metoprolol. Regarding beta blockers with membrane stabilizing action, take note, again, everyone, kindly take note that these beta blockers are not instilled into the eyes. Okay? So not instilled into the eyes. So hindi sila ina-administer sa ating mata. Okay? It is recommended, it is highly recommended that these drugs should not be given into the eyes. Question, why? Okay, bakit? Ang isang effect ng beta blockers na ito, may local anesthesia. Kaya pag in-administer sa mata, nag-i-induce sila ng anesthetic effect sa mata. O anong implikasyon nun sa mata? Napipigilan nila ang pagkurap natin. Okay? They can inhibit blinking reflex. Okay? So nabablock nila ang pagkurap natin sa mata. Siyempre, important ang pagkurap. Otherwise, matutuyo yung mata natin. So pag na-inhibit nila ang blinking reflex, that can damage the cornea. Okay? That could result to corneal injury. So that would result to corneal injury. That's why they are not administered in the eyes. Okay, bawal. Okay, everyone. These are the classifications of beta blockers. So regarding the classifications, let's recall them. Balikan natin sila. Una, for beta blockers, nabanggit natin na ang general MOA, they block what receptor? Beta number, common sa lahat. Anong beta number? Beta 1. Okay?
1.
Common sa lahat. That's right, beta 1. And then, meron tayong dalawang ways to classify beta blockers. Selectivity and miscellaneous. Pag selectivity, may beta 1, merong non-selective at may beta 2. Pag miscellaneous, merong ISA, may membrane stabilizing, may alpha 1 blocker. Okay? So these are the classifications of beta blockers. So bago tayo mag-health break, tingin kayo sa taas ng PowerPoint, meron akong idadagdag na special beta blocker kasi wala siyang specific group dito eh. Lone siya, lone. And that is nebivolol. I repeat, we have nebivolol. Ang nebivolol is deemed as the most cardioselective beta blocker. This is considered as the most cardioselective beta blocker. And what's distinct about nebivolol is that it enhances the level of the so-called nitric oxide. Okay, again, nebivolol is the most cardioselective beta blocker. And ang distinct about nebivolol is it increases the concentration of nitric oxide in the body. Nitric oxide is important vasodilator. Kaya ang effect ultimately ng nebivolol aside from cardioselective activity, vasodilation. Okay, vasodilation. So that's distinct about nebivolol. Now let me emphasize that we cannot classify nebivolol under this group, the one highlighted in green. Why? Ba't hindi natin pwede i-grupo? Because although both groups have vasodilating effect, the mechanism behind vasodilation is different. Yung kanina, alpha blockade. Pero ito, hindi siya related sa alpha blockade. Kaya we cannot add nebivolol under this group, yung may alpha 1 blocking effect. Do you get it?
Yes.
Okay, so very good. So far, we were able to discuss the direct acting sympatholytics, the examples. We were able to finish the alpha and the beta blockers. So right after the break, we will proceed on peripherally acting. So nandito na tayo after the break. Are we good so far?
Yes po.
So let's continue. After we discuss, balik tayo sa slide na to ha. After we discuss direct acting sympatholytics, let's proceed on peripherally acting sympatholytic agents. Guys, when we say peripherally acting sympatholytic agents, these are the drugs that can inhibit, they inhibit the normal physiological release, the normal physiologic release of norepinephrine from the vesicles. I repeat, peripherally acting sympatholytic agents are the ones that inhibit the normal physiologic release of norepinephrine from the vesicles. And these agents are called as adrenergic neuronal blockers. Okay? Adrenergic neuronal blockers. So examples, we have reserpine, guanethidine, guanadrel, and also bretillium. Particularly for reserpine, na-discuss natin to actually kahapon, reserpine is the drug that inhibits storage of dopamine from the vesicle, right? So, mapipigilan ang pagpasok ng dopamine sa vesicle or mas store, mapipigilan. And then for guanethidine, guanadrel, and bretillium, these agents inhibit release process. Okay? These agents inhibit release of norepinephrine from the vesicles naman. Okay? Para lang ma-reinforce yung diniscuss natin kahapon, ganito siya, okay, based on what you learned yesterday. Remember, we have the process wherein dopamine will enter the vesicle, okay? And then, mako-convert siya inside into norepi. And eventually, norepi will be released via exocytosis. Nare-recall ba tong mechanism na to kahapon?
Yes po.
Okay, very good. Now, ang ginagawa ng adrenergic neuronal blockers, they alter these processes. Okay, they alter these processes. Like for instance, for reserpine, it blocks storage of dopamine. Reserpine blocks the storage. While these drugs, yung tatlong ito, they block exocytosis, which both in turn will inhibit the presence of norepinephrine in the cleft. And pag hindi natin na-observe ang norepinephrine sa cleft, no receptor activation. Okay? Mabablock ang receptor activation. Kaya ultimately, we tend to inhibit sympathetic effect. Okay? We tend to inhibit sympathetic effect. So that's the mechanism of action of adrenergic neuronal blockers. Naintindihan ba ang MOA ng adrenergic neuronal blockers?
Yes po.
Okay. So yung figure na to guys, na-discuss ko na siya lahat kanina. So you can just check them out. So meron tayong peripherally acting, na-discuss natin, inhibitors of storage and also release. And then we have alpha and beta antagonist. Kaya let's now move on to the clinical uses of adrenergic blockers. So iisa-isahin natin ang mga clinical uses nila. Starting off with non-selective alpha blockers. Recap, for non-selective alpha blockers, we have phenoxybenzamine and also phentolamine, right? In general, these drugs are being used in the pre-surgical management of a condition called pheochromocytoma. What is pheochromocytoma in the first place? Ang pheochromocytoma ay isang disorder that affects the adrenal medulla. Okay? So this affects adrenal medulla. That is, merong enlargement or tumor rather, a tumor in the adrenal medulla. So this is characterized by presence of tumor in the adrenal medulla. Everyone, yesterday we were able to mention that the adrenal medulla is a specialized gland that stores what? Catecholamine. Ano major ang ini-store niya? Very good. That is epinephrine. Okay, very good. So it stores primarily epinephrine. So the problem in pheochromocytoma, may bukol, kaya may tumor siya. So anong implikasyon pag may presence ng tumor doon? If you are familiar, ang ating adrenal medulla ay nasa superior part ng kidney. Halimbawa, ito yung kidney natin. Nasa ibabaw ang adrenal gland. At isa doon ang adrenal medulla. And syempre, if you are familiar, ang ating kidneys ay nasa likod, bandang tagiliran, nandito siya. Okay? Sa bandang dito, hindi kasi kita ng camera eh. Naka-short lang kasi ako kaya hindi ako makatayo. So, nandito siya banda sa likod. Pag nakapamewang ka, dito nakapwesto. O ba't ko siya sinasabi? Kasi, ang problem sa pheochromocytoma, kapag may bukol sa inyong adrenal medulla, konting palpate lang. Palpate is pindot. Bawa, ito yung likod mo. Pag pinindot mo siya, konting pindot, that triggers too much release of epinephrine. May konting galaw, pipitikin mo, pipindutin mo, merong excessive release of epinephrine. So anong implikasyon nun pag may too much secretion ng epinephrine? Ang daming epinephrine na magbabind sa mga receptors. Ano ba ang ginagawa ng epinephrine sa receptors? Halimbawa, sa alpha-1, nagko-constrict siya ng vessels, hindi ba? And then, sa beta-1, anong ginagawa niya sa beta-1? It can stimulate the heart. So taken all together, when you have pheochromocytoma, small palpation, minimal palpation at your back, that can cause hypertensive cases. So nagkakaroon ka ng hypertension, palpitation, and tachycardia. Naintindihan ba? Do you understand?
Yes.
Feeling ko nawala ako. Nawala ba ako?
Hindi po, sir.
Hindi. Okay, sige. Nagets nyo yung effect, bakit nagkaka-hypertension, etc., etc.?
Yes po.
Okay, kasi may too much secretion of epinephrine. Kaya, yung mga tao na may pheochromocytoma, very careful tayo sa paghawak sa area na makikita ang adrenal medulla, okay? Such as sa likod, okay, sa likod. So ngayon, anong implication or ano ang relevance of using non-selective alpha blockers? Guys, ang best way to treat pheochromocytoma, the best way to treat this is surgery, okay? Better ang surgical removal ng bukol kaysa naman gumamit tayo ng long-term na gamot. Okay? Mas okay na operahan siya. Kaya lang, syempre, kapag ooperahan ang tao na may pheochromocytoma, kababanggit ko lang, konting galaw, magkaka-hypertension ka, and so on. Lalo na pag surgery. Syempre, pag surgery, konting galaw dyan, baka mamatay ang pasyente dahil inatake siya. Okay? Kaya, kailangan natin ng pre-surgical drug. Pag sinabing pre-surgical, meron tayong ina-administer na gamot para kahit galawin yung part na may bukol, hindi magsasuffer ang patient sa simptomas like hypertension, palpitation, and tachycardia. Kaya gagamit tayo ng mga non-selective alpha blockers. Okay? Particularly, these agents can target alpha-1 receptors. They block alpha-1. Blockade of alpha-1 receptors would result to what? Is it enhancement or reduction of blood pressure?
Reduction.
Yes, very good. So reduction of blood pressure. Do you think ma-address natin yung issue pag ginalaw yung bukol?
Yes po.
Yes. So at least nako-cover, okay? Nako-cover na prevent yung komplikasyon, okay? Kapag inoperahan yung patient. That's right. However, you must note that palpitations and tachycardia cannot be covered by alpha blockers. Kaya usually for palpitations and tachycardia, beta blockers ang ina-administer. Okay? Beta blockers. Nevertheless, naintindihan natin yung connection of using non-selective alpha blockers. Okay? Yan ang kanilang general use. But I repeat, the best way is to remove the tumor. Okay? Next, proceed tayo sa specific uses ng mga drugs na ito. First, we have phenoxybenzamine. Phenoxybenzamine can also be used for carcinoid tumor and also mastocytosis. Sa carcinoid tumor, ang reason why phenoxybenzamine can be used for carcinoid tumor kasi meron siyang additional anti-serotonergic effect, okay, because of its additional anti-serotonergic activity or anti-serotonergic effect. Okay? Next, what about for phentolamine? Okay, phentolamine. For phentolamine, this agent can be used in the treatment of tissue damage caused by accidental infiltration of alpha agonist. What do we mean by this? Guys, remember, pag sinabi nating alpha agonist, what's the effect of these drugs in the blood vessels? Anong effect ng alpha agonist sa blood vessels? Vasoconstriction or vasodilation? Activate, activate.
Constrict.
Yes, very good. Constrict. So ang mga alpha agonists, they can cause vasoconstriction. And di ba nabanggit natin, like sa mga catecholamines kanina, kapag merong exposure, too much exposure to alpha agonists, that can cause digital necrosis. Di ba namamatay ang mga tissues? Naalala niyo yung sa daliri kanina?
Yes po.
Okay, so yun yung ibig sabihin dito. Kapag ang patient halimbawa ay may digital necrosis or tissue damage, we can use phentolamine. Why? Okay, bakit ulit? Kasi ang phentolamine, it blocks alpha-1 which causes what? Vasoconstriction or vasodilation?
Vasodilation.
Dilation na. Very good. So vasodilation already. Wherein, maka-counteract na ngayon ang constriction effect or necrotic effect. Very good. Okay? Check tayo sa unang use. Next use of phentolamine. This drug can be used for rebound hypertension or hypertension. And this is caused by overusage of certain medications. So rebound hypertension, pwede din siyang gamitin. Often, ang rebound hypertension is caused by using clonidine. Okay? This is caused by clonidine. And to counteract that, we can administer phentolamine. Okay? And finally, erectile dysfunction. So right now, i-discuss natin ang relevance of using phentolamine for erectile dysfunction. First, let's analyze what erectile dysfunction is. Ang erectile dysfunction is also known as impotence. Okay? Impotence. And this is being experienced by elderly male patients, of course, sa lalaki. And it is characterized by inability of an old man for self-erection. Hindi na niya kaya mag-erect mag-isa despite of several stimuli. Di ba normally, kung meron tayong mga stimuli para mag-erect ang penis, it will happen so. It will do so. Okay? Pero sa mga matatandang pasyente or some susceptible male patients, despite of the stimuli, trigger na nakikita nila sa paligid, kahit gusto ng utak nila, hindi ginagawa ng penis nila. Kaya impotence ang tawag doon. Now, para maintindihan natin ang koneksyon ng phentolamine sa erectile dysfunction, ipaliwanag natin briefly how the penis erects. Okay? With the presence of stimulus, normally, kapag merong triggering factor para mag-erect ang penis, ang ugat sa penis, they relax, they dilate. Okay? They dilate. And because of relaxation of the vessels in the penis, more blood goes into the penis. Mas maraming dugo ang pupunta sa penis. And when the time comes that more blood is observed in the penis, it will erect eventually. Kaya usually, ang penile erection is caused by more blood reaching the penis. Kaya 'di ba, yon, okay, penile erection, more blood, makikita, well-perfused rather ang penis. Now, in patients with erectile dysfunction, ang problem, one of the possible problems is less ang dugo na napupunta sa penis. Ay less na ang dugo na napupunta sa penis. Yun ang reason ba't gumagamit tayo ng phentolamine. Kasi ang phentolamine, I repeat, has a vasodilation effect. Okay, it has a vasodilation effect. So do you think more blood will go into the penis using phentolamine?
Yes po.
Yes, kaya it would facilitate penile erection. And mind you, ang phentolamine is being administered injectable, okay? Locally administered siya, okay? Injectable siya, locally administered into the penis. So ituturok mismo ng injection yung phentolamine sa penile shaft, okay? Penile shaft. Local, okay? Locally administered sa penis mismo. Question, is this something good or bad? Sa tingin nyo, pag tinurok mismo sa penis yung phentolamine, is it something good or bad? Sa tingin nyo? Sige, any idea? Okay lang yan kung ano, kung ano yung tumakbo sa isip nyo. Is it something beneficial or no? Nawala ba ako ulit? Hello? Huwag na kayo mahiya. Sige na, go. Ha? O regime, ano? Sa tingin mo?
No, sir.
No. What about the others? Something good or bad? Hmm? Bobbies, ikaw. Bad naman, Bobbies. Ah, Tam, ikaw Tam. Sa tingin mo, good or bad?
Good po.
Good.
Okay lang.
Bakit? Idea. Sige, okay lang kung ano yung raw
Um,
idea.
Since nagkakaroon po ng more blood on the penis.
Oo.
So, di na siya dysfunction.
Okay. So, nice argument. O sige, i-guide ko kayo ha. Tingnan natin kung ano yung magiging final answer nyo, kung good or bad. Guys, ano ulit ang rason bakit mag-e-erect ang penis because of phentolamine? Does it relax or constrict the blood vessel?
Relax po.
Relax, very
po.
good. Kung gusto mong i-treat ang erectile dysfunction, anong ugat ang dapat mong targetin? Ugat lang ba sa penis? Yes or no? Yes,
Yes po.
very good.
Yes.
What's the point of discussing those? Guys, kapag ang isang gamot ay gusto mong gamitin for erectile dysfunction, as much as possible, localize lang dapat siya. Kasi at the end of the day, ang effect ng gamot ay vasodilation. Ugat ang marerelax. Come to think of it, if you take a drug by mouth, pero ang intention mo is to erect the penis lang, oo, the penis will erect, but since you took it by mouth, the effect is systemic. Not only the blood vessels of the penis will relax, but the other blood vessels or arteries around your body would also be relaxed. Kaya ang pwedeng maging effect nun, aside from penile erection, hypotension. Naintindihan nyo? Pag systemic, okay. So it's something bad pag systemic kasi tandaan yung matatandang pasyente to. Very risky pag nag-hypotension sila. Maaari silang mamatay. Okay? Kaya ang phentolamine, pag locally administered, it is a good point. Okay? Beneficial siya kasi less toxic siya. Okay? Less toxic. Naintindihan na less toxic kapag local administration?
Yes, sir.
Okay.
Sir.
Kaya 'di ba yung ibang mga drugs for erectile dysfunction, Viagra if you are familiar, delikado Viagra kasi by mouth siya iniinom. So masyadong bababa ang blood pressure ng matanda. So anong importance niyan? Bilang pharmacist, syempre ang alam lang ng mga matatanda, nagpapa-erect lang siya. Hindi nila alam ang mechanism behind. So it is important to counsel the patient na hindi lang basta-basta nagpapa-erect ng penis, may dahilan kung ba't siya nag-erect. Paano kung may iba siyang medication na ginagamit to lower blood pressure? Eh di namatay na talaga siya. Okay? Kaya you have to consider that. Next, okay na tayo guys sa non-selective. Moving forward, we have selective alpha-1 blockers. Particularly for tamsulosin and alfuzosin, these agents can be used in the symptomatic relief of benign prostatic hyperplasia. Basically, ang benign prostatic hyperplasia is characterized by prostate enlargement. Okay, prostate enlargement. Naaalala ba yung discussion ko sa prostate gland kahapon?
Yes po.
Okay.
Yes.
So recall, 'di ba, ang prostate gland, for example, in the figure on the left side, ito yung prostate gland, yung naka-highlight ng green. 'Di ba nabanggit natin, during prostate enlargement, chances are the amount of urine na supposedly i-excrete na-obstruct natin, okay, na-alter natin, such that limited ang nailalabas. Kaya in male patients with BPH or enlarged prostate, the amount of the urine being excreted is so minimal. Okay? Kaya we can use alpha-1 blockers because by blocking alpha-1 receptors, the prostate gland or the prostatic smooth muscles tend to relax. And relaxation of the prostate gland facilitates efficient excretion of urine. Okay? Kaya ginagamit siya for symptomatic relief. Kaya nakalagay dito, management of urinary hesitancy and then prevention of urinary retention. Now, ano yung gusto nating i-emphasize during BPH? Please listen carefully. Sa pasyenteng may BPH, ang dahilan kung bakit lumalaki ang prostate, that is hormone-based, okay, hormonal. May hormonal factor siya. Halimbawa, testosterone in males. So hormonal factor yung paglaki. And epekto ng paglaki ang hirap sa pag-ihi. Ngayon, dapat nating tandaan na yung simptomas lang ang tinitreat ng alpha-1 blocker. Yung simptomas na hirap sa pag-ihi. Pero the size of the prostate itself, it cannot be addressed by alpha blockers. So hindi nila kayang i-shrink yung enlarged prostate. So kung gusto nating i-shrink yung enlarged prostate, gagamit tayo ng hormonal agents na doon. Did you get my point? Okay.
Yes po.
Kaya sa indication ng alpha-1 blockers, ano lang sila, symptomatic relief. Kaya nakalagay dyan, urinary factor lang yung ina-address. Next, for prazosin, doxazosin, and terazosin, they are often called as antihypertensives because they are vasodilators. Okay, these are vasodilators. They block alpha-1, so there is vasodilation, apparently. Okay, those are the clinical uses of alpha blockers. Recall, for the clinical uses, we have clinical uses of alpha-1 blockers and then non-selective alpha blockers. Sa alpha-2 blockers, although not indicated, rarely used lang kasi ang alpha-2 blockers. Yung yohimbine, halimbawa, ay yung yohimbine. Ang yohimbine, ang use ng yohimbine ay for erectile dysfunction. Ang use ng yohimbine ay for erectile dysfunction. Next, let's proceed to the uses of non-selective beta blockers. Regarding non-selective beta blockers, di ba yung mga NSTP as we remember, ang applications sila are arrhythmia. In fact, in antiarrhythmic agents, they are termed as class 2 agents. Okay? So they are termed as class 2 agents. You will understand what does class 2 mean pagpunta natin sa drugs for arrhythmia sa latter part ng midterm. And then we have acute panic syndrome. One of the manifestations of panic syndrome is tachycardia. Okay, one of the manifestations of panic syndrome is tachycardia. Of course, non-selective beta blockers are cardiac depressants, so they can be used for that condition. And then migraine, yes, ginagamit din sila for migraine, but as prophylactic agent only. A prophylactic agent. Particularly, the one being used is propranolol. Particularly, the one being used is propranolol. So these are non-selective beta blockers. What about for cardioselective beta blockers? Cardioselective beta blockers applications are antihypertensive sila. So they are being used as antihypertensive agents but not first line. Okay, they are not first line. And then anti-anginal agents. That is because these drugs can lower oxygen demand by the heart. Okay? Because these agents can lower myocardial oxygen demand by the heart. Madidiscuss natin ang angina sa bandang gitna ng midterm grading period. So maiintindihan nyo pagdating sa angina what is meant by decreasing oxygen demand. Okay? Next, these drugs can also be used for congestive heart failure, but take note, in general, beta blockers are contraindicated to heart failure patients. Pero meron tayong 4 na exceptions. Okay? Sila lang. So dapat makabisan nyo sino-sino sila. These beta blockers are bisoprolol, metoprolol. Again, ang pwede lang for heart failure patients are bisoprolol, metoprolol. And regarding metoprolol, we have plenty preparations or salt forms for metoprolol. But the one useful for congestive heart failure patients is the succinate salt, metoprolol succinate, and then carvedilol, and then nebivolol. Repeat natin, we have bisoprolol, metoprolol succinate, carvedilol, and nebivolol. Next, these agents can also be used in thyroid storm. So in particular, we use propranolol in this case. We use propranolol in this situation. So ginagamit siya for thyroid storm or hyperthyroidism. Okay, for hyperthyroidism. Everyone, sa finals, madidiscuss natin ang propranolol for hyperthyroidism. Doon ko may explain ang mechanism leading to anti-thyroid effect. So ngayon, isipin nyo muna pwedeng gamitin for hyperthyroidism ang propranolol. This will make sense pagdating natin ng finals. And then, pwede rin silang gamitin as prophylaxis for migraine headache. And ginagamit din sila for glaucoma. Okay, they can also be used for glaucoma. Now, the reason why they can be used for glaucoma because they lower inflow of aqueous humor. So they inhibit synthesis of aqueous humor. But for the drugs, for the beta blockers that can be used for glaucoma, selected lang ang gagamitin natin. That is timolol, carteolol, and betaxolol. Others should not be used. Lalong-lalo na yung mga may local anesthesia effects sa mata, 'di ba? They can affect, they can cause corneal injury. So these are the clinical uses. And then, ito na-discuss ko na, beta blockers with alpha-1 blocking effect, ginagamit sila yung selected drug for heart failure. Particularly, ang ginagamit nga dito si carvedilol. Kasi si carvedilol ay may alpha-1 blocking effect sa mga drugs, yung 4 na beta blockers na nilista natin a while ago. Okay, so done discussing the clinical uses. So recap tayo ng clinical uses, everyone. We were able to discuss the applications of alpha blockers, particularly the non-selective, the alpha-1 selective, and then the alpha-2 selective. Also, we were able to tackle the uses of beta blockers. So these are the following. Finally, sa outline natin, we have the toxicities or adverse effects. Unahin natin ang alpha blockers. Alpha blockers can cause the following adverse effects. Number 1 is reflex tachycardia. Okay, number 1 is reflex tachycardia, which is common with the use of non-selective alpha blockers. Now, pag sinabi natin reflex tachycardia, this is a compensation of the body because of the trigger, because of the problem. Remember, we are talking here about non-selective alpha blockers. Based on your learnings, ano nga ulit ang effect ng alpha blockers? Is it vasodilation or vasoconstriction? That is vasodilation. Very good. And what do you expect on the blood pressure? Pag may vasodilation, bumababa ang blood pressure. Okay? So bumababa ang blood pressure. Kaya pag gumagamit ang patient ng alpha blockers, pwede magka-hypotension. And take note, because of this trigger, normal na mag-compensate ang katawan natin to address this. And the compensatory mechanism of the body is to cause reflex tachycardia. Okay? That is, bumibilis ang tibok ng puso para tumaas ulit ang blood pressure. So part yan ng compensation ng katawan. Okay? So normally, ang paraan para ma-block natin ang reflex tachycardia is to use beta blockers. Okay? That is to use beta blockers. Kasi they target the heart. Okay? Next, we have nausea and vomiting that is observed with the use also of non-selective alpha blockers. Also, we have orthostatic hypotension. So what do we mean by orthostatic hypotension? Ang orthostatic hypotension, that is lowering of blood pressure, pero ang usual cause ay whenever you change body position. For example, pag ikaw ay nakahiga, pag ikaw ay nakaupo, nakatayo, tumatakbo, nakatihaya, nakabaliktad, iba-iba ang blood pressure mo doon. Okay? Pero thank God, kahit nagbabago tayo ng body position, hindi tayo hinihimatay. Kasi active ang ating utak in compensating that. However, pag ikaw ay gumagamit ng alpha blocker, nahihirapang makompensate ng katawan natin yung sobrang pagbaba ng blood pressure. Kaya ang impact nun sa katawan when we use alpha-1 blocker, pag bigla tayo nagbago ng body position, ina-hypotension tayo agad. Ano ang perfect manifestation ng orthostatic hypotension? Ito yung bigla nagdidilim ang paningin mo pag nagbago ka ng position. Napansin nyo ba minsan na pag malilate na kayo sa school, from lying flat in bed, pagising mo, na-realize mo na malilate ka na, biglang tayo ka, tas nagdilim ang paningin mo. O kaya, may nalaglag kang gamit sa ilalim, kinuha mo, tas bigla kang upo ulit, nahilo ka ng konti, orthostatic hypotension yon. Naintindihan?
Yes po.
Okay. So, pwede siyang i-induce ng mga alpha-1 blockers. And worse here is pwedeng magkaroon ang patient ng first dose phenomenon. A first dose phenomenon. Pag sinabi nating first dose phenomenon, that is at the first time intake, at the first time administration of alpha-1 blocker, pwede siya magkaroon ng syncope because of orthostatic hypotension. In Tagalog, sa unang inom ng alpha-1 agonist or antagonist, alpha-1 blocker, hinihimatay siya. Syncope is hinihimatay, okay? Papass out, okay? Hinihimatay. So that is exaggerated orthostatic hypotension, okay? Caused by first dose administration of alpha-1 blocker. So para mapigilan natin ito, meron tayong recommendation sa pasyente. Usually sinasabi ito ng doktor or kina-counsel ng pharmacist. So ang remedy natin dito is take the drug at bedtime. Okay? Take alpha-1 antagonist or blocker at bedtime. So take alpha-1 blockers at bedtime. Siyempre pag tulog ka, nakahiga ka, di ba? And ang rationale dyan is, nakahiga ka while the drug is active in your body. So when the time comes na nagising ka, less active na yung gamot, so lesser chance na himatayin ka. Okay? So yun yung reason why we recommend the drug to be taken at bedtime. And then, common adverse effect also, which is paradoxical, is sexual dysfunction with the use of non-selective alpha blockers. These are the adverse effects caused by alpha blockers. What about beta blockers? For beta blockers, meron silang effect na cardiac, adverse effect na cardiac, meaning affecting the heart, and then extracardiac. For the cardiac effect of beta blockers, we have bradycardia, AV block, and heart failure, which are directly related with the drug SMOA, which are directly related with the drug SMOA. You know that beta blockers are depressants, so pwede ito mangyari. And then, na-discuss ko na to kanina, asthma can also happen or could also be exacerbated, especially for non-selective beta blockers, yung NSDP. Next, there could also be augmentation of hypoglycemia. Again, there could also be augmentation of hypoglycemia. So ang beta blockers, they can lower blood glucose levels. They can lower blood glucose levels. Kaya dapat minomonitor natin ang blood sugar when a patient is using beta blockers. And also we have other metabolic effects like lipidemia, and then central effects like sedation, fatigue, and sleep alterations, dizziness, and in some cases, orthostatic hypotension. Okay? So these are the adverse effects caused by beta blockers. Next, what about adverse effects of adrenergic neuronal blockers? Reserpine can cause depression because it can lower serotonin levels. Okay? Because it can lower serotonin levels and also norepinephrine levels. These are actually mood regulators. Again, for serotonin and norepinephrine, these are both mood regulators. And it is noted na pag mababa ang mga compounds na to, that could make us sad or depressed, clinically depressed. Okay? And then bradycardia, GI disturbances, and extrapyramidal effects. Extrapyramidal effects, this is due to lower levels of dopamine in a patient's body. Okay? This is because of less dopamine levels in the body, and extrapyramidal effects could affect motor activity, okay? Motor activity of the patient. Next, proceed naman tayo sa mga central inhibitors of sympathetic outflow. Although these are agonists, remember, although these are agonists, may isip natin na inhibitory ang effect nila kasi they can inhibit the release of norepinephrine. So ano ang mga adverse effects nila? Number one, for methyl dopa, para hindi kayo mahirapan, mag-focus tayo sa major effects ng methyl dopa. Ang major effects sa methyl dopa ay sedation and positive to Coombs test. Ang pinaka-common, again, ang most common adverse effects or adverse effect ng methyl dopa ay sedation. Okay, sedation. Now, focus tayo sa positive Coombs test. Para maintindihan natin ang ibig sabihin ng Coombs test or positive Coombs test, i-explain muna natin ang principle of this procedure, yung Coombs test. Again, discuss muna natin what is Coombs test. Ang Coombs test ay isang diagnostic procedure to check the presence of antibody that destroys red blood cells. Again, for Coombs test, this is a procedure which determines the presence of antibody that destroys red blood cells. And ang dinedetect na antibody dito is the one that can hemolyze RBCs, that can hemolyze or pinuputok niya yung red blood cells. Yan ang antibody na dinedetect sa Coombs test. Now, relating to methyl dopa, ang methyl dopa ay may kakayahang mag-produce ng antibody na ito. Okay? Antibody na nagde-destroy or nag-hemolyze ng red blood cells. Kaya noted na pag gumamit ng methyl dopa, maaari siyang mag-induce ng positive result sa Coombs test. So pag nag-positive sa Coombs test ang pasyente, ano ang conclusion ng doktor? Ang conclusion ng doktor is posibleng merong hemolytic anemia ang pasyente. When we say hemolytic anemia, anemia is bababa ang red blood cell ng tao. And hemolytic means the reason of RBC reduction is hemolysis. Okay, hemolysis. Kaya pwede mag-result ito sa hemolytic anemia. Nagets ba yung Coombs test and hemolytic anemia?
Yes po.
Okay.
Yes po.
So very good. Finally, we are on the last slide. Ang important lang sa clonidine na adverse effect ay rebound hypertension. O yan na lang ang tandaan nyo kay clonidine. Okay? So clonidine can cause rebound hypertension. So paano ba nangyayari ang rebound hypertension caused by clonidine? So regarding rebound hypertension caused by clonidine, this is because of sudden withdrawal of clonidine use. Okay, again, that is because of sudden cessation from exposure or sudden withdrawal. Kaya in some references, ang tawag natin sa rebound hypertension caused by clonidine is clonidine withdrawal induced hypertension. Okay? Kaya sa ibang libro, ang pangalan ng effect ay clonidine withdrawal induced hypertension. Kasi nangyari ang hypertension nung in-stop mo, nung winidraw mo ang clonidine. Okay? Kaya rebound hypertension ang tawag. Okay? So that is the reason. Now, para matreat natin ang rebound hypertension caused by clonidine, we have to administer clonidine again. Okay? So we have to administer clonidine again. And if not, pwede rin naman ang phentolamine o kaya captopril. Okay? So treatments include clonidine, continuation of clonidine use, and then phentolamine and also captopril. Okay? Siguro may magtatanong, di sir, forever na niyang iinumin ng clonidine? No, no. Why? Sabi natin, nangyayari ang rebound hypertension pag sudden, pag bigla mong in-stop ang gamit. Kaya para maiwasan ang rebound hypertension, you have to dahan-dahan, you have to taper the dose. Babawasan mo gradually ang dose para maka-cope up ang katawan natin hanggang mawala na ang clonidine. Okay, so that is because of sudden withdrawal. So yan ang major adverse effect ng clonidine. Okay, so yan ang major adverse effect ng clonidine. So altogether, we were able to discuss the adverse effects caused by using sympatholytic agents. So balikan natin ang outline for sympatholytic agents. When we say sympatholytics, these are adrenergic antagonists. So 4 ulit ang parts na diniscuss natin dito. So para pag gumawa kayo ng outline, structured siya.